And so we'll give everyone a couple of minutes to join, but I think we're already getting people logging in. So welcome everyone. As you join, please feel free to chat with all the other participants, and let everyone know who you are and where you're from. We will get started in a few minutes. Gloria, remind me, are you in Abuja or Lagos?
I'm in Abuja.
Have things all settled down after the election?
Yes. Everything is fine. Surprisingly, everywhere is calm, and we hope it remains so.
Fantastic.
Are you in Nigeria at the moment, or you're planning to visit?
Not until likely September or so.
Okay. So are you coming to Abuja?
Probably. I think that would be where we would go. Yeah.
Okay, so we'll get to meet then.
Exactly.
Yeah.
Will you be going to Aortic this year, Gloria?
Where?
Aortic.
Maybe. Let's see. Last year Ronsi was around, so he went. So probably go for this year since he's not in the country. I might represent him. Who knows? Yes. So I might, but I'll let you know. You'll be going, right?
I will be. Yes.
Okay. So if I will, I'll let you know. We'll catch up.
Perfect. Claudy and Cheryl, Aortic is the big African organization for research and training in cancer, and they have a biennial meeting every other year. Peter Kingham goes to the meeting fairly regularly.
That's nice.
Yeah. Maybe we can get you to come over as well.
That'll be nice.
So we're about 4 after the hour, and I see we have a good group of attendees. Everyone, please feel free to introduce yourself in the chat. And I think, Gloria, if you would like, we could go ahead and get started. Gloria, would you like to introduce our special guest from the ACT Foundation?
Yes, please. Thank you very much. Okay, so thank you and good afternoon, everyone. My name is Gloria Oku, the program coordinator for Project Pink Blue. And I want to thank all of you, the panelists, the presenters, and the participants, all of you that have taken out time to make yourself available for this training. We say thank you very much. And because today is the last day of this training, we have our funders in the room, our big partners that have been partnering with Project Pink Blue to implement the Upgrade Oncology training, which is the reason why we are having this training today. So we have somebody from ACT Foundation today. Her name is Oluchi, and she's going to say a word or two for just maybe 2 minutes, just to address everybody and for them to see how well we are doing with Upgrade Oncology. So I would like to welcome Oluchi Okorafo from ACT Foundation Nigeria to say a few words. Oluchi.
Hi, Gloria. Thank you very much. Good evening. It's evening here in Lagos. Um, Thank you all. As Gloria said, my name is Oluchi. I'm an M&E executive at ACT Foundation. In case you didn't know, ACT Foundation, we're an indigenous organization. We were established to support organizations addressing health, environmental, social, and economic challenges plaguing the continent, Africa. And we support implementing partners such as Project Pink Blue to address some of these challenges, provide innovative solutions, and build sustainable communities. Um, I think since our inception, we've worked with so many organizations on different um, cancer interventions at different levels, whether it be awareness, patient navigation, screenings. And we're very happy to have had a robust partnership with Project Pink Blue, most recently since 2021 on the Upgrade Oncology program. I think last year was more focused on supporting pharma oncology. So we're very happy to be supporting this phase of the program. I guess so much has been taught over throughout the trainings of this program, but I mean, for today, I know that, for example, pain management is a very important issue when it comes to cancer care, especially for patients and their families. So our foundation is happy to support such an important training. I want to thank all the facilitators here today. Everyone here today, Katie and Claudia and Cheryl. Thank you so much for putting your efforts and bringing your skills to help other professionals in your field to continue to improve cancer care in Africa. I think that I hope that this training would increase the understanding of the role of opioids, but also hopefully shed light on best practices. I know both of you are discussing some debates on opioids, but I hope that you share insights on best practices for all the professionals here today. So once again, thank you to all the participants, nurses, doctors, different professionals. Thanks for participating, and I hope that it will improve your ability to provide better care to patients. And ACT Foundation will continuously remain committed to supporting interventions that address quality cancer care on the continent, and hopefully will continue to reduce the ever-rising cancer burden on the continent. So thank you once again, and I'm looking forward to listening in on the conversation. Thanks, Gloria.
Oh, thank you very much, Oluchi. We're so happy to have you. Thank you so much. So over to you, Katie. Thank you.
Thank you very much. And so without further ado, good afternoon and evening, everyone, and welcome to our last lecture for the Upgrade Oncology lecture series for nurses and clinical oncologists. It's my pleasure to introduce you to today's speaker, Dr. Claudy Aime-Baptiste. Dr. Aime-Baptiste is a nurse practitioner at the Memorial Sloan Kettering Cancer Center in the US, and she will be giving today's lecture on the role of opioids in pain management. So thank you, Dr. Aime-Baptiste.
Thank you, Katie. Good morning, everyone. Good morning, everybody else on the panelists. It's a pleasure and an honor to be here. I'm from the US. It's morning time. For anybody else, is it afternoon or evening? So good afternoon, good evening. For those who speak French, bonsoir, bonjour. Mon nom c'est Claudy Citella Aime et je suis une nurse practitioner at Memorial Sloan Kettering Cancer Center in New York. For the purpose today, we're going to have this presentation in English. Like I said again, thank you for having me. It's a pleasure to be here. Our subject today is going to be about opioid, the role of opioid in cancer pain management. I know lately opioid, the stigma associated with opioid internationally and especially in the US I think the problem remain is it's a lack of understanding and also support system. So I'm hoping the presentation today will give us a better insight about the opioid use and how opioids should be used, and also our responsibility as providers. We have some responsibility in the way how we prescribe opioid and also to our patient. The objective of this presentation today, as I said before, the provider will understand the role of opioid management for cancer pain, and also understanding the use of long-acting versus short-acting opioid to optimize the patient pain. And also the provider will be more comfortable when they're prescribing opioid. I think one of the barriers that we do have in the profession is how comfortable are we when we prescribing opioid? If you're not comfortable to prescribe it, we need to find out where is the problem line, what is causing that? Because we need to be able to prescribe opioid safely and responsibly for our patient in order for them to get a relief or to optimize their pain relief. What is opioid? Opioid have a long history in human history. It's been there for the longest time, as much we can remember. Opioid is a substance made from 2 or sometimes more elements, and that sometimes chemically joined and used mainly sometimes as one or as an oldest medication to manage severe pain, especially in cancer patients. Also, it can be used for recreational purpose, and that's where the big problem is coming in, because sometimes people has a difficulty to separate the clinical aspect of the use of opioid or the recreational purpose of it. The adequacy and efficacy of opioid therapy made it the primary modality in cancer patients. It's very efficacious when it's used safely and responsibly. Over the years, cancer patients have been treated with opioid as a single agent, like I mentioned before, or also sometimes in combination therapy. Opioid activate a region in the nerve cells called opioid receptors, which inhibits pain signals between the body and the brain. All opioids work in the same way. Opioid drugs may be referred as, we know, painkiller, opiate, or narcotics. Whether it is used legally or illegally, opioid can cause what they call euphoria. That's for the reason sometimes people use opioid illegally. But at the same time, my belief is I don't think a patient or anybody say, I'm gonna try to get opioid for the euphoria, but sometimes it's the habit that leads patient to the disease. And yes, the long-term use of opioid can be very addictive and lead to disorder, opioid disorder. Cancer-related pain is very complex and multifactorial and may worsen as the disease progresses. As the patient disease progressing, patients tends to have more pain and the pain intensity increases. So sometimes that lead to increase their opioid, and that's what lead patient to a higher use of opioid utilization. Moreover, cancer pain itself has been associated with poor survival. The survival of these advanced cancer patients taking opioid may be more likely to be associated with the cancer disease itself, not the opioid use. Adequate treatment of cancer pain has the potential to improve quality of life and performance status, highlighting the importance of continuing to use of opioid to manage patient pain efficiently. Opioid mainly act on the central nervous system via various opioid receptors. Opioid receptors also exist outside the nervous system. Previous studies have emphasized the role of opioid to cope with environmental stress, mechanical, thermal, and chemical, deep tissue injury, pathogen invasion, inflammation, and tumor growth. Type of opioid, we have exogenous opioid as a non-peptidergic opioid receptors agonist, are low molecular weight, substances that can be classified according to their synthesis mode into natural opioid, isolate them from the plant Papaver somniferum that we know sometimes as opium, morphine, or codeine, semi-synthetic opioids like oxycodone, heroin, hydromorphone, and buprenorphine, also known as Suboxone, and synthetic opioid, fentanyl, tramadol, or methadone. Moreover, based on opioids' interaction with their receptor and affinity, they can be classified into 3 categories, namely agonists, partial agonists, and antagonists. Some opioids have dual agonist and antagonist function. Full agonist function like full agonists such as codeine, fentanyl, heroin, hydrocodone, methadone, and morphine, and oxycodone can interact with opioid receptors and produce like a maximum response to significant alteration in the receptor structure. Partial agonists can trigger minor adjustment in receptor activation compared to a full agonist. Both full and partial agonists at low dose can demonstrate similar effect to their full agonists of the same generation. Although the analgesic activity of partial agonists does plateau following increasing of the dose, further increase in amount will not provide additional relief. So instead, it may increase adverse reaction or adverse effect. Example of partial agonists include buprenorphine, tramadol. Like mixed agonists and antagonists, you like buprenorphine again, butophenol, nalbuphine, and pentazocine may do the opposite. Besides buprenorphine and butophoril and nalbuphine, we don't use that. And even buprenorphine, you have to be certified sometime as a Suboxone in order to prescribe that to patients. Type of opioid. The endogenous opioid system comprises a type of 7 transdermal guanine, nucleotide binding protein, they call that the G protein, including classical receptor, a mu receptor, delta opioid receptor, kappa, and other receptors. Among all the opioid receptors, the mu opioid receptor is a therapeutic target for most clinical use opioids, including morphine, fentanyl patch. Likewise, the mu opioid receptors can mediate the analgesic activity of opioid in the central nervous system and secondary effects such as addiction, respiratory depression, and constipation. Opioid agonists include partial agonists like bupropion and full agonists like methadone have an important role in patients with cancer pain. Both of these medications are effective analgesic and are also indicated treatment for opioid use disorder, meaning that they use them for pain relief, but also if a patient have a disorder or they become, they misuse opioid, they can use them to effectively get them off the abuse that they experiencing. For example, buprenorphine provides effective and strong pain relief and also offer an advantage over transdermal formulation. Its role in the treatment of cancer pain is still evolving due to we have not enough evidence. Methadone was found to have similar benefit to morphine and was determined to have a role in the management of cancer and neuropathic pain and opioid use disorder. So methadone, a lot of people know methadone as a regimen for opioid use disorder, but methadone also have a strong have strong benefits in cancer pain or regular pain. It can be a somatic pain or non-somatic pain, and also neuropathic pain. So what I do usually when I'm thinking about to switch my patient in our clinic, in our practice, to switch patient to methadone if they feel like drug like MS content or OxyContin or fentanyl patch. So I tell them I think it's time to try methadone. The first reaction patient have said methadone, no, because of the stigma attached to methadone. This is the time as a provider you make an environment for your patient to be free to ask questions about why are you thinking about the methadone as a regimen for their pain. And that's when you take any type of interaction with your patient is a chance for education, to educate your patient about any medication, any situation. For example, like methadone, they probably know only the stigma that attached to it, and because of that they will say no, I don't want it. But once you take the time to explain to them the benefit of methadone as far as like for pain relief and neuropathic pain relief, the good side of it, and also you're honest about the side effect, patient tends to be more open to try it. We cannot talk about opioid without talking without pain. Pain occurs in 50% of patients with cancer, and approximately 10 to 20% experience severe pain. Nearly 1/3 of cancer survivors experience chronic pain, where the individual experience pain over like 90 days or longer. We have patients who had cancer. Thank God their cancer, they survived the cancer, but some of them remain with chronic pain. And sometimes you need to come up with a regimen once the patient pain is getting better to start reducing the patient's medication. There are several ways we can do that. And I always say these talk, you don't wait when things get better or patient is a NED or the patient is survived the cancer to start talking about it. This is a conversation that needs to start taking place from the first meeting. You let the patient know the idea is to give them relief from their pain, to optimize their quality of care. And once their pain subsided, we're gonna start talking about taping them off the medication or reducing their medication. More or less, when you start from the beginning of the conversation, you let patient know about your intention, the goal, patient is more open to talk about opioids or their medication. Because some of them, from what they're hearing on the street, they are so afraid to even try even a Percocet, because they say, I don't want to get addicted. So all this inside when the patient is talking to you, you need to take them into consideration and see about what is the best approach to talk to your patient about different type of modality, different type of pain medication that you might think that may be helpful to them. This type of pain is frequently treated with prescription opioid. Although opioids are the most efficient treatment for moderate to severe pain and generally safe with short-term use. What do we say about short-term use? That's when you have a patient that come into your office, you need to figure out exactly how long you think they might be having pain. Is it an acute pain that you might just need to use a short-acting one, or if the patient's gonna have other treatment that's gonna increase their pain, that's when you decide which treatment or pain medication that you bring on board with the patient. And also keep in mind about the type of pain the patient is having. The use of opioid therapy long-term carries numerous health risks. It could be mental and physical, include increased risk of new onset of depression, exacerbated chronic depression. Cancer-related pain is complex, like we said before, and it also may get worse as the disease progresses, leading to higher opioid utilization. Moreover, cancer pain itself has been associated with poor survival. So I always, from our clinic, what we do, we always try to use the multidisciplinary approach, meaning that yes, we are treating the patient pains, and the pain can be treated with opioid, which is the main reason that we're here today. So sometimes in order to treat the pain, we need to look a little bit further besides the physical aspect, meaning that you need to speak to your patient about what is going on to their minds, facing based that they face a diagnosis, they just got diagnosis with cancer. Also look the family dynamic, how patient is coping with all this. It's news about the cancer that they would just got diagnosed, they find out about it. So sometimes the patient, based on the conversation you have with the patient, but remember, you have to make an environment where there is honesty, transparency, and trust between you and the patient. That way the patient can be more comfortable to let you in, and that way you'll be able to type in from different aspects of their lives. Other things that we do sometimes, I reach out to my counterpart from their primary team, the doctor that is taking care of their cancer. So I reach out to them to talk to other patients, see, how do they feel about certain things, because sometimes they know them longer than I do. So from their inside point, I put it together, I talk to the patient, I realize, okay, this is the best approach to talk to that particular patient about their pain regimen. And also you realize that besides the medication, that the script that you're writing, you also need to refer the patient to a psychologist or social worker. But sometimes they're really hesitant to accept that referral. So based from the insight that you have, then you can be able to have the patient agree to meet with a social worker or a psychologist. So that way you're not only taking care of the physical aspect of the pain, because pain is also mental, then you'll be able to kind of like treat the patient as a whole. So adequate treatment of cancer pain has the potential to improve their quality of life and also to enhance their well-being, their mental aspect. Because when you're in pain, everything went down. And sometimes that's when patients become very dependent of the opioid, because remember, some people, when they take the opioid, it makes you very sleepy, drowsy, and sometimes that euphoric sensation that you get, it's trying kind of like to take you away from the reality that you live in. And that's when sometimes some patients fell into depression if they've been using the long-term opioid over a long period of time. So depression is a sign of long-term opioid use. It's very common in adult patients with cancer. Depression is about 20 to 30% of cancer patients, nearly 25% of patients in palliative setting. For patients with cancer, long-term opioid use may lead to depression in terms to complicate recovery and increase risk of mortality. Cancer patient is associated with 3.5 times greater risk of feeling depressed and 2.5 times risk of feeling anxious. When you meet patients who just got diagnosed, the anxiety level is very high. Some of them, they are depressed. They're not even able to connect with you, to explain to you how they're feeling. That's what first encounter with the patient, it's always good to offer the patient psych and social worker referral. Once they're able to verbalize their feelings, sometimes they're not able to do it to their own family members, but by meeting with somebody that doesn't know them, they're able to open more and let them know about their feeling, because they don't want to bother the family members about their mental aspect. They want to keep everything to themselves, but we know that the more they open to somebody, or professional, or even a friend, that will help them cope with their cancer diagnosis and sometimes even with their pain. Pain interference with cancer to continue to predict depression, largely in male patients within a year after a cancer diagnosis. As we know, male patients have the tendency to keep things inside because they have to show that they are strong compared to female patients. Depression is associated with more than twice the risk of hospitalization due to opioid poisoning and opioid abuse or addiction among patients with cancer. The next slide is a pathway that shows you how, from the time that patient is prescribed opioid, where does it lead? From the time they got diagnosed with cancer, they're having pain, then they have increased long-term opioid therapy. increase of opioid dose that lead to dysphoria and hyperalgesia. Then from there, they can end up, some of them can be into hyperkatifia, which is anhedonia, dyspnea, depression, opioid misuse, opioid use disorder. Then what going to all this, the adverse outcome is definitely is going to lead them to overdose, suicide, and mortality. Before we go into the long-acting period, acting opioid, it's very understanding why patients in the use of opioid long-term can lead to depression, because sometimes as a provider, when they come, they let them know we're gonna try to get their pain better, but what they fail to understand sometimes as the time go by, the disease progressing, that increase their pain, and the patient feel like there's no way from there they're gonna continue to have this pain, or there's not going to be any changes in their life. And especially if they were active patient, they were doing so many things, and now they're not able to do it, they start asking themselves, why bother? What is the point here? Or they say, where can I go back to my regular activities? And that will lead them to deep depression. And sometimes some of them, they go so deep that they could go into, like, they use the opioid as a way to escape reality, and sometimes that lead to overdose. From the overdose, then that can lead to mortality. So that's why it's very important that as a provider, you learn to know your patients and know exactly the changes in their life. That way you'll be able to capture those changes and make appropriate changes where it's needed. Talking about example of long-acting opioid, we have the fentanyl patch, which is a transdermal medication that you apply to the patient's arm or where it's comfortable for the patient. Fentanyl, usually we use them every 72 hours, but some patients, when they pass the 48 hours mark, they start feeling pain. So we do it every 48 hours. It's all individual based. Like I said, pain management is not one size fits all. It's based on individual symptom. So we can use fentanyl patch every 40, usually it's every 72 hours, as I said, but based on the patient's symptoms, is we can use it every 48 hours. It's very important to let patients know that to use them when you use fentanyl patch, to use them exactly, to remove them and exchange them exactly at the 72 hours mark or 48 hours mark. If not, that is not being done, patient can start having what they call withdrawal symptom. So that's one of the major education. You have to talk to patient about that. The other thing is, the other education is explain to patients, some patients, sometimes they do get pain relief by using heating pads. So one of the things I tell my patient all the time, we tell a patient, please try not to apply direct heat to the fentanyl patch, because it's going to make it go faster, and that can lead to toxicity and withdrawal. Then the next one, long acting that we use is methadone. For example, if a patient failed MS content, OxyContin, they fail fentanyl patch as a higher dose, the next one we usually go to is methadone. And usually we get good benefit for the patient, good pain relief for the patient, and patient really, once they get started and get relief, they're starting to understand that the difference between the myth, the stigma they have outside, and once the medication is being prescribed and monitored safely. So methadone is a very good drug. It's good for pain. And also, if you have a patient that fails neuropathic agent like gabapentin, Lyrica, and you need to put the patient on that with an opioid, methadone is a good one because it does have effect on neuropathic pain as well. Another one we have is oxycodone extended release. That's a long acting as well. And in our clinic, we don't use it as often. We tend to use MS content if that's what the insurance company will pay for, or a new drug that they have. It's not new, but it's newer than oxycodone, is Extemza. It's almost the same family. What I like about the Extemza is a capsule pill extended release, that they make it that way that the patient, people that have addiction, they cannot break it or open it, compared to OxyContin when they can crush it into use it in different way that it wasn't meant to use. The last one is morphine. I think you guys are very familiar with morphine. The last time I had the presentation, I had a lot of questions about morphine. Is extended release. And also they have the short release. What I like about morphine, if you have a patient with cancer, especially his lung cancer, not only it will help with their pain, but also help them breathing better. Patient that we put on that, they always like it when they say that the pain was worse and he was having a hard time breathing due to the cancer. When they start that, they felt better, their breathing got better. So we like to use morphine for that. But if also the patient has any type of allergic reaction or adverse reaction to the other one, if they respond to morphine, so we put them on morphine as well. And sometimes some insurance company, when you ask for prioritization for other drugs like Extemza, hydromorphone, extended release, they're like, no, they're not gonna cover it. Morphine usually is one of them that they have on the list as alternative. Short-acting opioid, we talk about morphine, this is morphine IR. Usually we start the short-acting if a patient has an acute pain and we know we're not gonna keep the patient on opioid for a long time. Short-acting sometimes will be the best way to go. This is oxycodone IR, hydromorphone IR, and this is a Vicodin, is hydrocodone with acetaminophen. I think you call it hydrocodone and parathor, I think you have down there. And this with Percocet is oxycodone with Tylenol. Now, what are the considerations that we have to think about opioid? One of opioid consideration would be, like I said, introduce short-acting opioid for pain when the pain is an acute pain, is intermittent pain. Also for patient that fail, let's say if the patient come with like a neuropathic pain, but they cannot have gabapentin, Lyrica, or Cymbalta for whatever reason, they cannot tolerate those drugs, you could use the short-acting one for these patients. Or if patient cannot use long-acting one because of the fact that the dose are too strong for them, or they cannot keep having them in the system, make them very drowsy, or they're not themselves, or they having nausea or vomiting, everybody's different, then you could try short-acting medication opioid for them. When to consider long-acting opioids, if let's say you put a patient on a as needed medication, you tell them to use it every 4 hours or every 6 hours. Let's say the patient end up needing the medication more than every 4 hours, or they're taking it every 4 hours around the clock because of the pain, then usually what I told my patient is when you're using the PRN medication, the short-acting one, keep a log of how often do you use it. When we meet, I'll go over the log with them, and then if the log per the log that they have, then that make a decision, it's time to move them to a long-acting. Also, like I said before, you switch patient to long-acting if you know that the pain the patient is experiencing is going to be something over a long period of time. That's when you let the patient keep a log to see how often they use the PRN, because if they're using the short-acting very often, so you need to find a medication which is a long-acting that's going to keep them on a straight line instead on a roller coaster up and down. Once you find a medication that keep the pain stable for them, so it's better to keep them with that long-acting during maybe radiation therapy or maybe during chemotherapy. Also, you could use a long-acting for medication if the patient is waking up from sleep because of the pain every night. Because you have patients, they say, I haven't been able to get even 2 hours of sleep at night, or I can't even sleep, I have to sleep on my recliner because of the pain. So this is a time also to introduce a long-acting opioid for the patient, in order to provide them with pain relief. Other opioid consideration is of a long-term use of opioid. Remember, a long-term use of opioid can lead to addiction, depression, suicide, opioid misuse, Constipation is a big one. That's why whenever you start a patient on any type of opioid regimen, the next regimen that you talk to the patient about is a bowel regimen. You could start with something very simple as far as like senna with colace. Some patients say, you know what, by just drinking my prune juice, I'm fine. So as long that whatever regimen that they are doing is working for them, it's okay, they can continue it, but they need to be on the bowel regimen, because you don't want to wait. It's when the patients are having major constipation to introduce them to the bowel regimen, because the constipation can lead, severe constipation can lead to bowel obstruction. Then you don't want to go there. So from the beginning, you put a patient on an opioid regimen or a narcotic pain regimen, you need to start them on a bowel regimen, or at least talk to them about it. If they're doing something that is helping them and they don't have no constipation problem, you have to make sure to let them know the moment their bowel habits change, they need to talk to you about it. Also, nausea is one of them. Usually what we do, if a patient is on oxycodone, they said, I cannot take the oxycodone, although it does help my pain, but I cannot take it because it causes a lot of nausea and vomiting. So usually what we'll do is we will switch them over to dilaudid or hydromorphone, and usually it works for them because of, based on patients' feedbacks, they feel like the dilaudid has less a problem with nausea. They have less nausea with dilaudid, or they don't have it at all. Let's say if none of them, only one medication really relieve their pain, but it still causes them nausea, then you introduce them to antiemetic medication. You could try Zofran or ondansetron. If that doesn't work, then we can go sometime to Sancuso patch. That's a patch that you change weekly for them. It does help them with their nausea. Also, patient can have delirium when they start having hallucination. You switch them to another opioid, and also itching. And some patients, the same thing. A patient told you, oh, I'm having great relief from it. Other pain medication does not give me such relief. So you could compromise with the patient by trying to put them on a medication that's gonna minimize or prevent them from having the itching. So we're talking about opioids. So what do we do in the US or in our institution to prevent or minimize opioids abuse? There's one thing that they have in the US is nationwide. They call it PMP. PMP is the prescription monitoring program. What it does, it's a database computer-wise that when a patient, we check it every time we are prescribing an opioid to a patient. We do that first time when the patient is coming to you as a consult. We do it the same day because we want to be like a day-to-day activities. So what it does, it tells you when was the last time the patient was prescribed a medication, and when was the last time that medication was picked up from the pharmacy? Because if it's not picked up the pharmacy, that means they don't have it on hand. So once they go to the pharmacy and pick up that medication, the PMP will tell you, yes, that medication was picked up on such and such date by the patient. It can tell you up to 2 and 4 medication. So that way, when the patient comes to you, you know who else is prescribing the opioid to the patient. Because unfortunately, because of the opioid abuse and disorder, patients, they do what they call medication shopping. They could go from one provider to the next, picking up medication. And if these providers does not check the PMP, they will not know that patient had maybe 7 tablets of OxyContin last week or 2 days before. That's why you have to do it in real time. You check the PMP in real time. Even when my patient, I know them, they want to refill. When I get the refill request, before I do anything else, after I find out everything is working, their regimen is working for them, I don't need to make any changes. My next step is to go into the PMP to check when was the last time any medication like opioid was picked up by that patient. When I go in, if I see it was my name and it kind of confirm the last time I know that I sent it to the patient, fine, no problem, then I send it for the patient. But if I go into the PMP, I realize there's another opioid that was not prescribed by me, and it was done within a couple of days by another provider, that's a stop for me. What I mean by the stop is to stop for me to have a conversation with my patient to find out what is going on. Because remember, opioids are great, it's a great therapy for cancer patients, but if we do it responsibly and safely, our patient will get relief. So one way as providers to help prevent and minimize the opioid epidemic that we're having right now in our own capacity is whenever something doesn't feel right or doesn't feel right or doesn't look right, we need to stop for a second and speak to our patients, find out what's going on. There's so many other things that's going on, but we need to find why. And because one thing I always tell my patients from day one, if you're getting pain medication from any other providers, once you're here, you have to make the choice. Do you want me to continue to do your pain management, or do you want to stay with the previous providers? Because two different clinics or two different offices cannot be writing your medication. So the patient will say, you know what, I want all my record, all my medication be under MSK. So they know from the moment that they come to our clinic, they won't be able to go to another provider to get their drugs, because if they do, we will not write another prescription for them. That's another way we as provider can help that opioid crisis that we're having right now. The other thing that we do, they call it pain close care. If you know there's a patient that has some problem with abuse or misuse or kind of everything that's been going on, cancer diagnosis, they're very weak, they're not kind of in their clear mind. So we put them what they call pain close care. So whenever the patient comes, it pops in the computer, they call for their refill. If I'm not there, if it's another provider that the call goes to, that provider will see that headed, and then they will know, to pay more attention about it. For example, we had a patient, she was undiluted 4 milligrams every 4 hours, but she felt like the dose that we put her on was too small. It wasn't working for her. She was trying to get more medication. She will call over the weekend when she knows us that knows her will not be around. So what we did with that on the computer, when they call, they just tell her that as long as your pain is nothing new, so we have to be careful about that. As long as it's not a new pain, it's the same pain that you had when you spoke to the provider that usually sees you, please put a call out to them on Monday morning, and then they're not gonna give them any more opioid, or they're not gonna prescribe any more opioid for them. With that said, that doesn't mean that if the patient has a new pain or the pain intense, that they're not gonna help them out. They will help them out. But we have to put all this guardrails or safety in order to help our patient as well. Yes, they have a disorder. Yes, sometimes they will look into to get more medication, but we have to do our share as providers. Honesty, I believe in a relationship with a patient with pain. It could be cancer pain or pain related to other things. When it comes down to opioid, my belief is we need to have at least the H word, which is honesty, T for transparency, and also R word, respect. What I mean by that, once you have a mutual respect for the patient, between the patient and the provider, that's a great relationship because we respect each other. Honesty, always try to be as honest as you can. When I say as honest as you can, if there's a patient asks you a question, you don't know the answer to that question, let the patient know, I don't know the answer, but I can look into it for you. Transparency, let them know that you're looking for their best interest, their well-being, and the patient know that I'm not hiding anything from you. I'm not hiding anything that can give you better relief. So the patient knows that you are looking out for them. You have their best interest at heart. Always provide a nurture, a respectful, and this is the word, non-judgmental environment for your patient. Once the patient knows that, my provider is not gonna judge me based on the symptom I'm telling them that may require more opioids, or what I tell my provider, that's what they're gonna base on. Because remember, pain is what the patient tells you, not what you think it should be. That's where multidisciplinary approach is very good. Because if you have a patient that was diagnosed with cancer, and then after a while, the patient's pain is getting worse or worse, or you feel like the patient is requiring more medication than she should at that point, that's when it's always good to reach out to the cancer provider, the main team, the primary team, to say, oh, I have Mrs. So-and-so or Mr. So-and-so as a patient. So I read your note in record. So what's going on lately? That's when they can give you some insight. You know what? There's progress of disease, and that's why she's having more pain. Or the cancer is stable, but something else is going on. Then at least you know what's going on with the patient. Then you're able to treat your patient the right way, with the right approach. Instead, I think as far as like being the providers, one of the things that we are not honest about is our own biases. What I mean by that, it is we have to be able to ask ourselves how we really feel about opioid. And then from there, when we are truthful about our own feeling, we be able to help our patients, because our biases is going to make like a barrier between you and the patient. And in order to treat the patient properly and help the patient, if let's say the patient has misabuse, to help them come out of the situation, we have to be honest with ourselves. We have to be able to be more open about what's going on with the patient instead of on feeling. For example, I was trying to come up with a few case studies to explain the opioid use in pain cancer. We have patients with cancer that have other comorbidities, and sometimes the regimen that is appropriate for that pain, that the textbook tell us, it's not good for that patient. For example, I'm going to go over that case study. We have a 72-year-old man with a history of isolated plasmocystoma of the left acetabulum. He is status post of SCT since 7/24, and he remains NED. But he has chronic chemo-induced peripheral neuropathy and a left hip pain in the shoulder. This patient felt gabapentin, he felt Lyrica. So at this point, what do we do to ease the patient pain, to help the patient have a better quality of life? So as we were looking, we put the patient on Cymbalta, but the Cymbalta take the edge off, like the patient said, but it was not really give the patient relief, the relief that he was looking for. So finally, we make a decision. Why don't we do a small dose of opioid and see if that helped the patient, at least help him get back to his having a better quality of life and help him go back to his regular day activities. So what we did, we put the patient at first, we started him on oxycodone 5 milligram, which is the short relief one. And we did it for him every 4 to every 6 hours. And then the patient say, I'm getting relief, but I don't have to use it every 4 hours anymore, but I still have to use it every 6 hours. So then we ask ourselves, I say, should we continue with it, or is it one of the cases that he might require a low dose of a long-acting one? So what we did as a trial, we always do things as a trial, less invasive to more invasive. So we started him on OxyContin, 10 milligram, which is the lowest dose, for 7 days. Up to day 4, he calls us and said, my goodness, this is amazing. I can do things. So a patient like that, and then from using the OxyContin, he barely used the oxycodone. So from that point, we say, okay, let's do the OxyContin 1 milligram once a day and oxycodone twice a day. Then he calls back, he explained the pain to us, and we realized, you know what, maybe to make him feel more comfortable, as long as he's not having any side effect to it. So we put him on the OxyContin 10 milligram twice a day. And then we did the oxycodone twice a day as well. Then on follow-up visit, he said, I barely use the oxycodone now because the OxyContin and the Cymbalta really give me good relief. I don't need anything else. So what we do, another way what we did, not only to minimize any type of misuse and to have the medication available to the patient, we switch the patient to oxycodone 1 tablet a day. Why do we do that? Just in case he has a breakthrough pain and he needs relief, then he can have access to that 1 tablet. But in reality, from the last 5 months I've been seeing him, he haven't used the oxycodone at all. And when he called for refills, he haven't asked for oxycodone. He only asked for the OxyContin. This is one of the cases that in reality, you will not go to an opioid to treat the patient. But because we did not have any other option at that point, we tried something and we opened the communication line between us and the patient where trust, respect, and transparency was there. So we're able to give the patient quality of life, his quality of life back in a way. He's back doing his regular activity. And then if anything changed, he's the first one to call us and say, you know what? I had a pain last night. I had to take an oxycodone. And he'll be like, I haven't used it for 5 months. So that's what happened when I said you need to have a good relationship with your patient. It's a give and take. So now he's doing well, he's back to his regular life, just using the oxycodone and OxyContin. But in reality, for chronic induced peripheral neuropathy, or for somebody who has a left hip pain, we will go probably with gabapentin or an NSAID. That's what I said, it's not one size fits all. You need to find out what's worked for your patient. The other case study that I have, it's somebody that I met about maybe a month ago. It's a 63-year-old man with metastatic RCC. The patient, he's been experiencing the shoulder pain since January 14, 2023. And then MRI showed that basically he has degenerative disease, a bursitis. So the problem with this patient is we were thinking about a patient like that when they come to you, and also let me put this as a background, the patient also did receive CAR T-cell treatment. So when we think about the whole background of the patient, and also because of the problem with the kidney, I think he has 1 kidney, so we can't give him NSAID. Neuropathic agent is not an option. Even in low dose, he had some side effect to it, because we have to be careful with neuropathic agent when the patient has a kidney issue. Oxycodone, he could not get the oxycodone. So now I said to myself, at this point, what can you do? Somebody that's just have degenerative disease disorder and bursitis of the shoulder, I will not give them opioid. We don't do that. Opioid will not be the first thing for him. But when he came to us, his primary team had put him on Vicodin, which is hydrocodone and Tylenol. He said that's the only thing that gave him relief. But he's using it around the clock. So that's meaning he's going on a roller coaster up and down, up and down. His pain is never at a stable stage. There's not a straight line for his pain. So I said, all right, so why don't we try this? The first thing I was thinking about that he's a great candidate for a shoulder injection, a steroid injection. But I could not do that the same day, or I could not send him to my provider, the other providers that in my clinic with me the same day, because there's other things that is involved as far insurance wise. So I said, I need to find something to use as a bridge between the moment I'm seeing him until I can get him back into the office to get that injection. So I spoke to him, I said, why don't we do a lidocaine patch that is can be used as needed, 12 hours on, 12 hours off. And then we tried that for a week. because I had an appointment for him in 2 weeks to come to do the injection. But still his pain was not being controlled. So when he called and explained that to me, I said, okay, usually I don't put patient on opioid for pain, the type of pain that he has, but I has to put into consideration his comorbidities and what other treatment that he had in the past. So what I did, I said, okay, I'm gonna try the fentanyl patch, which is the opioid long acting, until we can get him in, because for the injection, because you can, once you do it safely and appropriately, you can get a patient off fentanyl patch. So he came, so we started him on the 12 microgram, which is the lowest dose of the fentanyl patch. I'm glad to say, by the time the patient came back to us to get the injection, he said he wasn't having any pain. But because the fact that also he's one patient that doesn't want to use any type of opioid for his pain, he was anxious to get the injection. So we did the injection worked for him. So what we did now, we took him off, actually last week, we took him off the fentanyl patch and we just leave the hydrocodone as needed for him. And the last report I got from him, he haven't used it, he only used it probably once a day. So this is the point I'm trying to make is opioid, once it's used safely and responsibly, can bring a lot of good things to our patient, meaning that increase their quality of life, improve their quality of life. And also then we can get them off depression, because if once you don't have pain, you're able to go to your regular activities, there's no time for depression. So in conclusion, opioid is still considered the preferred therapy for cancer-related pain treatment. Also, when you're able to treat the patient and also put in consideration the symptom and the side effect, opioid is still remaining the best option. Opioid, when, like I said before, it improves the survival. And also when patient doesn't have much pain from their cancer, they are more in compliance coming for treatment, because sometimes when you call a patient, somebody calls, say, why you call off? You didn't come for your treatment, or I was having so much pain, I didn't feel like getting to the car, even have somebody driving me. The only place I felt comfortable in stay in bed. And usually they stay in bed all the time. These are signs also of depression. So once we can use opioid to get their pain in better control, patients have tendency to be more compliant with their treatment. Emotional, once you know you're diagnosed with cancer, you have that emotional roller coaster up and down, and sometimes related to pain. We don't want to add more to it by getting our patient into depression. So that's why sometimes a check-in with your patient time to time, how they doing. The moment their pain is getting better, the moment the patient tell you they can go back to their regular activities, it's time to start reducing the opioid dose and give them something that is appropriate to them. And also it's time for me, there's no need to prescribe 140 tablet for a patient that barely uses medication, like they see out of sight, out of heart. Opioids still remain a controversial in our society, but at the same time, this is the best outlet for cancer pain related or sometimes for severe pain. We as providers, we have a responsibility to our patients, ourselves and other providers to prescribe opioids safely and responsibly. What do I mean by that? When you start opioid on the patient, you have to look into the patient as a whole, meaning that is the patient's symptom they're telling you makes sense. What I mean by makes sense, some providers, I don't know any of them, but I'm assuming they might just giving opioids, and that's when the door is open for patient to abuse the medication because of the euphoric feeling that they're getting. So if as a provider, you prescribe it responsibly, that means you not open the door or a difficult patient in a way to the next provider that is coming after you. you can tell your patient, I don't think this is appropriate for you. I don't think this is the right regimen for you. But once the patient knows that you have their well-being at heart, they will work with you. Don't just treat it that, oh, they want pain medication, I'm giving pain medication. No, sometimes that attitude led with more problem. I'd rather have a patient satisfied leaving my office, or having a patient, or even if they're mad at me, but in deep down, they realize they're satisfied with their pain relief, or having a patient that say, oh, I'm gonna go to Dr. So-and-so, he will give me anything that I want, and I don't put into consideration the patient well-being and how I can prevent that patient from going to the roller coaster of an opioid misuse or disorder. So regardless the stigma attached to opioid remain the best treatment for cancer pain-related patients. But we just have to be more cognizant about how we go about it as a provider, and also use multidisciplinary action approach to do so. So it was a pleasure for me to have this presentation to you guys. I hope it was helpful. Just want to say thank you to all the organizations that give us that platform to be able to do that presentation. Personally, I want to say thank you to Dr. Cheryl Barnes, Dr. Sana Sheikh, BVGH, MSK, my institution that I love so much, and Pink and Blue for this opportunity. And my email address is at the bottom if you have any question later on. It's been a pleasure.
Thank you very much, Claudy. That was a fantastic presentation. Throughout the presentation, you were getting a couple of questions, and I'm sure there will be more. Are you able to see the Q&A box?
Yes, let me go in there right now.
Fantastic. And everyone, if you have questions, please do add them to the chat.
Okay.
Or the
let me go from the top. At 1119, Yuma. If I said the name wrong, I apologize. Yuma Faruk, which pain management is the best for terminal ill patient? Well, let me say that first. It depends. When you say terminal ill patient, it depends. Are you talking about somebody that's already in palliative care, or somebody that have a stage 4 but still able to function? So it depends in which capacity that you're using terminal ill patient. But my answer to that is, once you know your patient, you try to use your best judgment. For example, if I have, and also you have to put in consideration the patient age. If I have a patient that is 72 or 82 years old and live at home by themselves, I have to put all that in consideration before I prescribe an opioid, because I want to make sure that the opioid or the dose that I'm prescribing is not going to lead the patient to have syncope episode or dizzy, where they're going to fall and have a hip injury that's going to make it worse. So my question to patient that is elderly patient that come to my office, I always want to know, do you live alone? Do you have somebody in the house with you, or anybody close that if anything happened to you that they can get to you within the five minutes? So I put all that in the question before I prescribe opioid to my patient. So as far as I said, terminal ill patient, based on the patient having, sometimes we use fentanyl patch, methadone. Like I said, it depends on which agent, which medication that alleviate the patient pains, and that need to have a conversation with the patient. That's the same thing that I said, is not one size fits all. Asoma, I'm sorry, Alexander, I have nurse patient that have used opioid to an extent they feel it's not working for them, and they result to overdosing. In this case, what advice you under such patient? That's at this point, that's what they call when they plateau with a drugs. When that happens, if the patient say that, oh, that is not working, then you could tell the patient, I have another drug, we can try it and see if we get better results. That's when it's time to switch the patient to something else. For example, I have patients that we give them oxycodone IR for immediate release or breakthrough medication. Usually we know that the immediate release medication, within 30, 45 minutes, they should start feeling better. If a patient tell me, oh, it takes an hour, it takes 2 hours, and for them to start feeling relief, getting relief from the medication, or if it tells me that it only lasts for an hour, I said, okay, this is time for us to switch to something else. Usually if they're already on oxycodone, if they don't have any allergy to dilaudid or hydromorphone, I will switch them to the equivalent dose of a hydromorphone. And usually they come back, they say, oh my God, this is working fabulous. So pay attention to what your patient is telling you in order for you to make changes. Yusuf Zainab, the teaching being preaching now is no addiction to oral morphine. How true is that? I'll be honest with you, addiction can happen with any drugs, all right? I think it's just how the drug is being prescribed and the patient affinity to that drug, because some people are more sensitive to another. And that's also to the point that you need to have that open and comfortable relationship with your patient, because patients sometimes when they start feeling the addiction or dependence on a drug, they can tell you. If that's the case, you could say, you know what, if you don't feel comfortable, continue because you feel you're depending too much on that drugs, we can try something else. Or you could even say to the patient, you know, maybe it's time to have a conversation. What is going on? What's going on in your life? What's happening? But as far as like a particular drug, patient does have no addiction to it, I will not be quick to say that, because addiction can happen with any drugs. Abdulaziz Adams, I'm sorry if I'm saying the name wrong. Good evening. The strong analgesic, though important for patient, has become out of reach to low-income patient, and where health insurance is limited. Are there alternative medication we can be easily afford to the common man? This is a great question. One of my challenges that I face every day at work is even patient with insurance. Like, for example, if a patient tell me, Claudy, I don't want to have to be taking drugs all the time throughout the day. So one of the drugs that I usually try to get patient is hydromorphone extended release, because this is one day. It's like one tablet, they take it daily. They don't have to take it twice or 3 times a day, just one tablet a day. And I will do a backup dilaudid or hydromorphone IR, the short acting one. And I know that will fit the patient lifestyle and what the patient wants. So I will order it for the patient. But unfortunately, sometimes the insurance company will not cover it, or they have something different. So what I will do is I will go to the list that they give me as alternative to see which one will be the best equivalent for that medication I want it to begin with. If I don't have anything else available, and I don't think, I hope I'm answering your question right. So what I will do is I'll try to come up with combination of drugs. For example, let's say if I know that the patient is having back pain, or the medication is going to be too expensive. Let's say if the patient is coming up with some intercostal pain to neuropathic pain, I will give them lidocaine patch, because lidocaine patch is very good for neuropathic pain as well, for the nerve. I will give them lidocaine patch, and then tell them to do some heating pads, like home remedies, if it's safe for the patient. Sometimes that's the best way. Sometimes your hands are tied, but home remedies are good. If they can have Tylenol during treatment, the primary team does not have any problem for them to use the Tylenol, I will tell them use Tylenol 5 extended release, 500 milligrams 2 tablets 3 times a day, no more than 3,000 milligrams a day. So sometimes you have to kind of think outside the box to help your patient in this situation. Or it could be a dose adjustment from a medication that doesn't have the same potency than the one that you wanted at the beginning. I hope that question, it helps. Okay, Abdullah asked another question. Can you combine 3 pain relievers to the patient in all lower dose? I've seen it done, but in my practice, I try to be very careful to do that. The combination of 2 pain relief that you might find that I do, I will probably order a short-acting medication for them and a long-acting one. And sometimes based if the patient also is experiencing neuropathic pain, you might see like a gabapentin or a Lyrica, but you most likely, you will not find 2 long-acting together. What I mean by 2 long-acting together, you're not gonna find methadone with fentanyl in my practice. Try to do it safely for the patient, but I've seen it done. What is the relationship between opioid use and stigma except the use of methadone? Well, because some people use opioid for non-clinical aspect, that you have people that is using opioid and then there's no control in the dose and they end up having overdose and leading to death. So that's what a lot of patients, when you're talking to them about opioid, they say they don't want it because they see people that use the opioid, they become dependent and more or less addictive to it. So that's the stigma that they think the moment that you start an opioid, that's the person that they're gonna become. And some of them, they rather be in pain than lead that road. So that's when you as a provider, you have to have a conversation with your patient, explain to them how dependency happened and how addiction happened, and explain to them that if anytime they feel changes in their behaviors, they should be free to come and talk to you openly. There's no judgment on your part. Then you'll be there to help them. How do you make the determination if a patient is addicted to opioid or take a decision to discontinue? This is what I do. I don't call it addiction at first. What I said, always tell my patient is, and their family, is a dependency that they develop. So if I'll give you a quick case study, I had a patient that used to be on oxycodone, short acting, 10 milligrams 3 times as needed. And that's why it's always good to get the family involved. The husband came to her with one of the visit and told me, you know what, my wife is not using it the way you prescribe it. I said, what do you mean? And he said, instead taking 10 every 8 hours, she's taking the whole 30. And after that, I'm scared and I don't want to leave her by herself. So what I did, I was so grateful for that insight. Without letting the patient knows that the husband told me what was going on. So I have a conversation with the patient. I say, how are you using your medication? Is it working for you? Because every time we see her, she said, everything is fine, everything is fine. So finally she tells me, she said, when I take the 10, it doesn't really work, but when I take the 30, it works. And after that, I need more. So what I did with her, I had a conversation with her. So I put on what they call the close monitoring. So I decrease her medication. I don't give her 30 days anymore. So I give her a short supply of 7 days. And as I give her the supply of 7 days, I introduce her to a long-acting one. So now every 7 days, she doesn't have a choice. She has to call me for a refill. So she doesn't have that medication readily available to her. And then another thing I did, because she was having neuropathic pain and back pain, I introduced her to Lyrica as well. So now all the even though yes, it might be a little bit more work for me, but it's okay, I'm helping my patient. So now every 7 days she has to call in, because she knows that if she called before 7 days, I'm not going to be able to refill her medication. By doing that, her pain is better controlled now. She barely used the short acting now, but every 7 days she has to call. And she tells me, she said, Claudy, thank you for the change. And I said, thank you to the husband that kind of opened my eyes to the problem. But sometimes they're very insightful. They will not tell you what's going on, but somebody will bring it to you. And then also she was trying to call more earlier than she supposed to. Like if you give her 30-day supply, she will call in 25 days. So I started to put one and one together, and then the husband started talking to me. I'm like, okay, then we need to come up with a plan and a regimen that's gonna work for her. So I did that, and now everything is working. Sometimes it's just having an open conversation with the patient. The next question, please, what do you do if you have a patient with addiction to opioids? Okay, so if you have a patient with addiction to opioid, the first thing we know, we need to find out what is the problem, what is the cause, and then we try to give them an alternative medication by reducing the opioid that is at cause, and also refer them to opioid addiction services, and that's how we help our patient. Okay, well done for the presentation. Is it advisable to discharge your patient home with opioid medication home, or you give NSAID? Yes, you can discharge the patient home with their opioid medication if it's necessary. If it's something chronic, if it's something acute, you could just give them a short dose for like maybe 7 days. If you know that within 7 days they should not be having pain, and then tell them use Tylenol if it's warranted. That means if they can use Tylenol, you could tell them use Tylenol for breakthrough. But yes, definitely patient can be discharged home with opioids based on what their circumstances is or what their pain is about. But you as a provider, make sure that you keep in touch with that patient, because what I do myself, when I know a patient has a problem, when they come to me, because I work outpatient, if I see them and their pain is not quite there where we want to be, I kind of keep giving them like a back and like a month follow-up visit. If I make changes in their medication, I give them a 2 weeks follow-up. So this close contact with the patient helps prevent a lot of things. Which pain management is best for cancer patients with other comorbidities like cardiac disease? Once again, you gotta pay attention about what type of pain the patients have. Yes, the patient might have cancer pain. The cancer pain might not be too severe, or the cancer associated with the pain associated with the cancer could be a neuropathic pain. So you usually, like my patient, if I know there's a history of cardiac, let's say the pain they're having is a neuropathic pain caused by the mass, where the mass is located. I haven't seen the literature, but I will go with Lyrica. So it's just based what type of pain are we talking about, and also what is causing the pain. And from there, I believe any low dose of opioid can be good for that particular cardiac patient, but then again, you have to look into more. For example, if somebody has cardiac disease, I don't like to put them on Celebrex if the patient doesn't need much opioid. I will have them, I will probably start them on like meloxicam for 14 days. And then after that, I'll look something else, or I'll ask them, speak to your cardiologist, ask him that if it's okay for you to start something like Celebrex, or is something, anytime I have any type of doubt, I don't act on it, I stop and look into it more. But I don't think there's a particular pain medication for patients with cardiac. Please, what is the best for treatment to give cancer patient who is on long-term use of opioid, who having severe constipation? All right, isn't it Chennai? That's what I said. The moment you start a patient on opioid regimen, you start a bowel regimen. But unfortunately, we have some patients that develop severe constipation due to the opioid. So there are medication that we give them, but usually before we go to these medication, we try everything else. We try to tell them use milk of magnesia, for the first 6 hours, like 15 ml. If they don't have a bowel movement, we say take 30 ml. If that doesn't work, we give them lactulose. Then if the lactulose doesn't work, then we use Semporic, that's medication we use for constipation, or we use Moventic, but we have to make sure the kidney functions are okay. But I always tell my patient, try what you have at home, which is sometimes good fibers. If there is no fiber restriction, prune juice. And one thing I tell my patient is if you like coffee, have your little coffee and put a little prune juice in it. It does major things. You won't believe it. And if, like I said, there's no restriction in fiber, oatmeal is very good. It's good for constipation and also heart disease. So why not using that in your advantage? Also tell them increase their fluid intake if there is no fluid restriction. So there are things patients can do for severe constipation or to prevent constipation. One of the things I told my patient to use is fiber gummy. Fiber gummy is very good for constipation. So there's, like I said, there are medication we can use for that, but I always start with the least invasive to the most one. Which part of the body is best to apply the fentanyl patch? And also, should we put all these patients on stool softener prune juice? Definitely. Let me continue with the constipation. Definitely, I tell my patient they can do the Senecart and the stool softener because I explained to them they both do something different. For example, patients say, oh no, I'm taking the stool softener. I'm happy you're taking the stool softener, but the stool softener, what it does is soften the stool. But what about you taking the stool softener and then you're not having anything? So you need the Senna that is gonna make you work to have the bowel movement. So I always take them, take the take the Senna and the Colis, whatever stool softener they're using. One of them that I like, I don't have any share in it, I like the Senecart S or Senecart Plus because it's less tablet for the patient take. It's a combination in one tablet. They have the Senna and the Colis in it. So instead taking 2 tablets of Senna and 1 tablet of Colis somewhere else or stool softener. So I tell them use that because it has all the ingredient in 1 tablet. As for the pumpkin juice, if it worked for them, yes, they can do that. And I tell them even eat the prune. If they have the prune available to them, eat that. Anything that can help with their bowel regimen. As for the fentanyl patch, we always tell the patient is good to back in the back of their forearm and rotate every time they use it. I think that's it for the question, Kathy. So.
Thank you so much. This has been a really fantastic presentation and I learned a lot and I hope everyone else did. So thank you all again so much for joining this lecture series. We hope you enjoyed it. My colleague Caitlin will be following up via email with more information and next steps around certificates of participation. Gloria, are there any final remarks that you would like to make?
Katie, no, maybe you maybe we'll talk about certificates, right? You mentioned to them that they'll get certificates for the number of courses they attended. Mm-hmm. Yes, and we also have certificates for the trainers who have been so magnanimous to spare their little time for us. So we have awards for them as well. So I think that will be all for now, except to have any other announcements. But Katie, when do you think they can get the certificates?
So we will download all of the attendance data. We also will be sending out a post-course survey and exam, which we ask everyone to fill out. We also ask everyone to share if they have other lecture topics that they would like covered in subsequent lectures. And then we'll be able to send out the certificates. And as Gloria said, the certificates will list each of the lectures that you attended live. So I imagine in the next 2 or 3 weeks, we will be sending out the certificate as we want to give people the opportunity to complete the survey.
Okay, that's nice. Thank you very much. Thank you, Claudy,
Yes,
Thank you,
thank
my
you so
pleasure.
much.
so
Thank
much.
you.
And thank you everyone for joining us. Thank you. We'll keep in touch, and we hope you join us for subsequent series. Hopefully,
That'll be my pleasure.
yes, yes. Thank you so much.
Thank
And
you.
thank you guys for making this happen. I think that's a great platform. Thank you for everything you guys do.
Thank you so much, Claudia. Thank you.
Well, have a wonderful weekend, all. And Claudia, I hope you feel better. Thanks again so much for the lecture, and wishing everyone a good rest of your weekend. And for those observing Ramadan, I wish you a very peaceful Ramadan.
Thank you. Same to you, and be safe, guys. Bye-bye.
Thank you. Bye.
Bye.